Thank you so much for the privilege of presenting at this virtual congress. I do not have any relevant disclosures. We have all seen patients with severe ulcerative colitis struggling in the hospital or at home with bleeding, malnutrition, multiple bowel movements, and dependency on the toilet. Many of them debating between perseverating on medical therapy or undergoing surgery. We know who needs surgery in acute settings: the patient with toxic megacolon, the patients with a perforation or near perforation, with peritoneal signs, with worsening colonic dilatation, with multisystem organ failure, with massive ongoing hemorrhage. Where it gets harder is when we are considering when to intervene and how to intervene on the patients who are failing medical management but are semi-stable. The days when we could simply use the Truelove and Witts criteria described in 1955 are gone. The number of bloody stools of more than 6, temperature, an increase in heart rate, a drop in hemoglobin, or an increase in ESR, those criteria are rarely enough today to drive us towards surgery as we escalate the medical regimen. And what's now left to us is a lot of clinical judgment and conversations with patients and the multidisciplinary team on the timing of surgery. And not surprisingly, in high-volume IBD surgeon hands, the outcomes improve, presumably because of the clinical experience and the access to open communications in the team. Clinical judgment also drives us towards the choice of surgery. The goal is an ileoanal J pouch and restoration of intestinal continuity, but very rarely that's appropriate in an acute setting as a one-stage procedure. Sometimes two-stage procedures are possible where a pouch is created and protected with an ileostomy. But the more common approach is three-stage with a subtotal colectomy first, or a modified two-stage. Many years ago, we wrote a paper worried that there may be a possible overuse of three-stage procedures for active ulcerative colitis and that more patients should be considered for either two-stage procedures or modified two stages. We wrote this manuscript looking at patients who had two-stage versus three-stage surgery at our own institution, where all procedures were done in high volume surgeon hands. And what we found that when you compared patients who underwent two or three-stage surgery, even if they had a similar rate of steroid use or anti-TNF use, they seem to have comparative cumulative 30-day readmissions and complications with comparable anastomotic leak and pouch failure. Reassuringly, their functional outcomes once ileostomies were closed also appeared similar. So why not always do a two-stage surgery, especially if it's cheaper, or a modified two-stage if the patient is frail and the concern for anastomotic leak is high? Well, there is more to it, as we all know. And when you look at the real-world scenarios, as recently documented in a IBD-specific NSQIP module, the majority of us in the real world still offer three-stage procedures for the majority of patients with fulminant UC, with the two-stage procedures being left in the hands of the surgeons who have the luxury of performing elective surgery. And why is it? Because our ultimate endpoint is high-quality life. And many patients with ulcerative colitis who have pouches struggle, even when everything goes well, with symptoms of ileoanal pouch syndrome, with some fecal incontinence, soiling, urgency, frequency, clustering, fragmentation, uncomfortable perineal symptoms, and nocturnal symptoms. Most of these symptoms are modulated by pelvic sepsis, and the only way we can control pelvic sepsis is by delaying J-pouch creation to the point where the J-pouch will not leak with or without diversion. To conclude, ileoanal J-pouch is a wonderful procedure that offers our patients the opportunity for intestinal continuity and in many situations a reasonable quality of life. It is an option of last resort for them. And as we think about whether we should offer them one, modified two, or three-stage procedures, we should guide these decisions based on how the patients look and also based on our expertise. We should not let our pride get in the way because the long-term patient quality of life is at stake. Thank you.